So where do we go from here? I want to be concrete, right? We've heard excellent presentations, and what does it mean for us trying to do research and development in this space? So I'd like to suggest that the absolute risk reduction is a key metric, and it was said in the morning presentation, and hopefully we can build some consensus around it. It's comprised of two pieces. It's the risk and it's the relative risk reduction. These two pieces are critical, and you can't focus just on one, and the metrics relate to it. The risk is inherently prognostic. To give an example, the recent AHA-ACC statin guidelines, they made a big shift to a risk-based treatment paradigm, and they argue they are really looking for benefit, but they're making a very important assumption that the relative risk reduction, the other piece, right, you estimate risk, but the other piece is pretty much constant depending on the treatment. That's a controversial assumption. We need to have two components. On the risk side, the prognostic, I think how to measure it, discrimination still is a key measure. Cecile had a really nice plot of the two curves moving apart, right? The distribution among those with events and non-events, the distributions of aggregated covariates. And I think I would argue that the AUC may not be the best metric for it. Cecile mentioned the NRI and the controversies with the measures. I think one of the better measures naturally going with that plot is a version of a Kolmogorov-Smirnoff distance, is a measure of statistical distance between the two distributions, which happens to have a lot of different good statistical properties tied to Uden index at event rate, and also incidentally NRI at event rate, right? So if you're doing it, it's a proper statistical metric. It's very simple. It's what the difference of risk of people above and below the event rate. But there we have other ones. We have Breyer score and rescaled version likelihoods. We can do it, and we can plot it. So the prognostic is set. Gets more difficult with the predictive, and I think what Patrick proposed is appealing, and it might be the best we have right now, what he calls the predictive score. He described it in terms of means. We can think about it in the context of events, right? What's the probability of an adverse event given treatment and a set of covariates minus the probability given no treatment and the covariate set or alternative treatment. And plotting it's very meaningful because we can see it across the range of the distribution of the risk score. So I think this is very appealing. Now, that gets very quickly to the issue how smooth the curves are and how it changes, right? So then we get to the point, well, in our simple regression mind, we'll think, okay, we have a score, we have an interaction with treatment, and it's all nice and easy. What Fan talked about, it's a very interesting potential disruption of this simple framework. Because why should I create a score and look for an interaction first? Why not interactions with individual variables or partitioning and getting more and more complex? And the methods Fan was talking about, right? These methods are really going crazy after the interactions. They have the possibility to do it. They might be going overly crazy, and we have to look at it, but the potential is there, and I think there is an army of engineers and computer scientists ready to apply these methods in this context. So I want to kind of make sure that we don't get too comfortable in our simple regression setting, and we look at these both worlds, and Fan talked about diffusion, which I very much agree with. But this is not all. We need to look at risk-benefit considerations, right? If the treatments we're talking about had no adverse effects, right, if it was eating kale, why not give it to everybody? Why worry? It's like you can just apply it and it happens. So the better quantification of the harms and the two-dimensional, multidimensional look in this space becomes critical. Importance of validation and the question, we're running a trial, we talk about, okay, let's have a trial, let's have a predictive score coming out of this trial. But trials, as pointed out earlier by Aniras, was if you talk about the trial run for regulatory purposes, the population is very narrow. by design, right? That's probably not descriptive of the population to whom we want to be applying these results. How do we expand the trial results? Do we like the really large, simple trials? That might be more useful, but it still may not be enough. What I care about is patients in our health system, right? What's their risk-benefit profile, and what's the context of the heterogeneity, not the patient already enrolled in a particular trial with particular limitation. So I think more open questions than answers, but a fascinating field. So look forward to the discussion.